Welcome, everyone. It's great to be here this evening for our second installation in our inaugural Distinguished Speaker Series program. And I want to start this evening with a piece of text or a quote from Israel Salanter. Israel Salanter, who was a great rabbi who ended up founding a movement called the Musar movement in the 19th century that was both an ethical and a psychological movement that really in some ways shaped our world even up until today. And so I'll share this piece that he shared with his students. He said that as a young man, I wanted to change the world, and I found it was difficult to change the world, so I tried to change my nation. And when I found I couldn't change the nation, I began to focus on my town. I couldn't change the town, and as an older man, I tried to change my family. And now, he said, as an old man, I realized the only thing I can change is myself. And suddenly I realized that if long ago I had changed myself, I could have made an impact on my family. And my family and I could have made an impact on our town. And their impact could have changed the nation. And I could indeed have changed the world. With our Distinguished Speakers series, we are continuing a way in which Temple Sholem has allowed us as congregants, as people who are part of Temple Sholem, to continue to change ourselves, inspired by these great speakers, in order to change our world. And so our Bima has had the likes of Eleanor Roosevelt, who was an advocate for poor workers and refugee rights. Martin Luther King Jr. spoke from our Bima in 1964 on civil rights. Elie Wiesel made real those words from our Torah that says, Lo tuchal lahit'alem, we must not remain indifferent to suffering around the world and also in our own neighborhoods. Brian Stevenson told us from our Bima to get proximate to communities across difference to root out racism. And Thomas Friedman said that in the face of an accelerating world, create communities of compassion and justice. He told us that from our sanctuary. Our Distinguished Speaker series is trying to do what we had done maybe once in a generation or even once in a decade, to have speakers come and inspire us to change ourselves in order to change our world. That it used to be that we would do that in a generation or once a decade. But through an incredible gift, we are able to offer this speaker series annually, to have distinguished speakers who are able to speak on the issues of our time with moral clarity, and also to help us to change ourselves and change our world. And it seemed this year that there was no greater issue of our time than to talk about equitable access to healthcare. And we know that in our own tradition, for a long time, all the way back to the Torah, in Exodus chapter 21, verse 19, we're told that if someone is injured in a fight, the assailant must pay for a person's cure. The words in Hebrew are "Baropeh Yerapeh." Somebody has to surely see to that person's healing. And the Talmud then explains that this gives us permission to practice medicine. And then a legal code in the 13th century makes it stronger and says that it is a mitzvah, a commandment to practice medicine, or more generally, to see to someone else's healing. And a few centuries later, the quintessential legal code, the Shulchan Aruch, takes it a step further and says that it is not only a mitzvah to practice medicine, but also to seek out medical treatment. It's not only a commandment to see to someone else's healing, we are required to seek out our own healing through medical professionals. So even in the Middle Ages, our sages made clear that an equitable system of healthcare was divinely mandated, a system in which a patient was commanded to seek out medical care and professionals were mandated to treat patients. Yet in the 21st century, in the greatest democracy in the world, we are not only still struggling to get this right, in many ways, while the healthcare itself is better, access to healthcare is less equitable than for many of our ancestors. So we heard already from Dr. Georges Benjamin, who showed the ways that trends before the pandemic and during the pandemic, the ways in which the pandemic laid bare these inequities. And tonight, Dr. Ezekiel Emanuel will further illustrate some of these inequities, but he will also show us what we can and must do to address them, both as a society and as a community of individuals who are changed in order to change our world. And so tonight, as we welcome Dr. Emanuel, who is known by many as Zeke, we also want to recognize that we have some special guests with us this evening. We have Mr. Dan Schwartzman, who is a past president of Temple Sholem and a member of the American Public Health Association. He's also the chair of the ethics section of the American Public Health Association. He's an associate professor at Loyola University of Chicago, Parkinson's School of Health Sciences and Public Health. And also, in order to be here this evening to learn from our distinguished speaker, we have Doctors Arlene Keddy and Craig Klugman. Dr. Keddy, who is the associate professor at Northern Illinois University College of Health and Human Services, and Dr. Klugman, who's a professor of bioethics and health humanities at DePaul University and directs DePaul's Bioethics and Society program. We also welcome this evening Dean Elaine Morato at Loyola University of Chicago, Parkinson's School of Health Sciences and Public Health, and Ms. Ellen Stein, director of the COVID-19 Contact Tracing and Epidemiology program in the School of Public Health at the University of Illinois at Chicago, as well as Dr. Ronald Hershow, director of the Division of Epidemiology and Biostatistics and an associate professor at University of Illinois at Chicago, as well as two pastors from our Chicago neighborhood, Pastor Alka Leal from Broadway United Methodist and Pastor Nanette Sawyer from Fourth Presbyterian Church. Wonderful to have these guests to be able to learn from you, Zeke. And so I have the opportunity now to introduce our distinguished speaker this evening, who I think in this crowd needs no introduction, but I'll introduce you, Zeke, nonetheless. So Dr. Ezekiel Emanuel, known by many as Zeke, is Vice Provost for Global Initiatives and the Diane S. and Robert M. Levy University Professor of Medical Ethics and Health Policy, as well as co-director of the Healthcare Transformation Institute at the University of Pennsylvania. He also serves as special advisor to the Director General of the World Health Organization. Dr. Emanuel is a leading practitioner shaping healthcare in the United States and around the world with a record of experience at the highest levels of policymaking, thank God, and is trained as an oncologist and political scientist. So Dr. Emanuel offers a uniquely thoughtful perspective on the most difficult issues in medicine today. In addition to academic and policymaking roles, he frequently contributes to the public discourse about a wide range of healthcare issues. His perspective is regularly featured in the New York Times and Washington Post and on CNBC and National Public Radio. Notably, Dr. Emanuel authored a provocative article for the October 2014 issue of The Atlantic entitled, "Why I Hope to Die at 75, that will soon be followed by an article by me that says, "Why I hope you don't die until you reach the age of 120. May you do so in good health." Most recently, Dr. Emanuel served on President-elect oh no, now President Biden's COVID-19 advisory board during the presidential transition. He previously was a special advisor for health policy in the Obama administration and a member of President Clinton's healthcare reform task force. And while special advisor for health policy, he was a prominent voice on healthcare reform and the Affordable Care Act. It is truly an honor to have you. I know that the last time, or at least a very memorable time that you were part of Temple Sholem was when you experienced a bar mitzvah of a friend, and Rabbi Binstock was leading the service on the day after Jimi Hendrix had passed away. And so we're glad to welcome you in that spirit back to our virtual Bima. Grateful to have you here. Thank you so much, Zeke.
It's a real pleasure to be here. And yes, I do think the last time I was inside was 51 years ago during the bar mitzvah circuit, where many of my friends were members of Temple Shalom. And it's certainly an icon. And when I give people tours of my life in Chicago, it's one of the places we go by, and I explain how often I was there as a child during bar mitzvahs. So it's a great honor here to be able to come and talk about healthcare and health equity and our responsibility. And I can only say that it sort of goes without saying that for Jews, ensuring that everyone gets health care, and more importantly, ensuring that everyone is healthy, is the utmost obligation. It's often said that without health, the rest of life just doesn't have meaning. It's hard to lead a fulfilling life. And since we are all committed to everyone leading a meaningful life, that was getting them health and healthy seems to be very important. I want to divide the talk up tonight, as brief as it'll be, because I want to hold a lot of time for your questions, because I know the Temple Shalom community is brilliant and very talkative, as it should be. I want to divide it into 4 parts. The first part is just a quick review of the data, and just to make sure we're on the same page about the disparities we have in our society regarding health care and health services. Then I want to talk about some of the things that have been done in health services and can be done in health services to remove those disparities. But I really want to focus on the things that we can do to really focus on health. We often confuse getting healthcare services with health, and I want to talk a little bit about that. Access to healthcare services is a good news, bad news story. The good news is we passed the Affordable Care Act in 2010, and it made a difference. 22 million or so people got health coverage, and it actually did a great job of narrowing the disparities between minorities and whites in particular. The uninsured rate among whites is about 7.8%. Among African Americans, it's closer to 12%. And that's a big decrease between whites and blacks over time. More importantly, Hispanics in particular used to have, before the passage of the Affordable Care Act, 31% of Hispanics were uninsured. Now it's down to 20%. But you can see the disparity remains. We've made great progress, but we haven't erased it. Maybe the best, most telling statistic about access to healthcare is the fact that we have about 30 million Americans still without health insurance, despite the Affordable Care Act, and half of those are people of color. So we have an enormous gap. Not only is it access to health coverage and therefore access to health services, the more important gap is a gap in our actual health outcomes. And here the gap is more glaring. And actually, unfortunately, it's not getting better, but getting worse. A life expectancy is an indicator lots of people follow. The gap between whites and blacks in terms of life expectancy in the United States was 4 years before COVID. And unfortunately, with COVID, in a very short period of time, it's increased to 6 years. That's an enormous gap in life expectancy. It's hard for me to overemphasize how important and how big that gap in life expectancy difference is. 6 years on average across two populations. Let me just give you another statistic that'll put that into context. I don't know if Rabbi Conover mentioned that I'm an oncologist. I trained as a cancer doctor at the Dana-Farber Cancer Institute in Boston. If we cured all cancers in the United States, every person who came down with cancer every year, we would increase the average life expectancy 3.3 years. So the gap between blacks and whites is even larger than curing all cancers in the country. It is simply enormous life expectancy. But we have other gaps which are, I think, pretty frightening. Take the case of diabetes, a devastating illness requiring constant attention for a lifetime. 20% of African Americans have diabetes, 13% of whites have diabetes. Take infant mortality. A travesty can affect someone terribly. Among blacks, it's 10.8 births per thousand. Among whites, 4.6. So double, more than double the rate. African Americans to whites. Maternal mortality is even worse. We have, for blacks, 41 per 100,000. For whites, it is 13 per 100,000. And let me just say, in most countries, it's below 10. Even the worst countries, it's about 5. So we have both terrible for whites, but really bad, 3 times the level of whites for African Americans. These are unacceptable statistics, and COVID has only made things worse. Again, as was mentioned, in the first phase of the pandemic, the rate of hospitalization and death among minorities was basically 4 to 5 times that among whites. So I want to just talk about what we can do. The first is to try to get coverage for everyone. We have 29 million Americans without health care coverage. This is after passage of the Affordable Care Act. The crazy thing is that 17 million of those 29 million, the vast majority of them, are actually eligible for Medicaid and for coverage in the insurance exchanges with government subsidies. We could narrow the uninsured rate, bring our coverage rate up to 97%. If we just got people who are eligible for coverage on. Unfortunately, states make it difficult, and largely intentionally, so that people don't get coverage. They make it complicated. They make them prove their income over and over again. They don't go out and alert them to the fact that they are eligible and actively recruit people. If they show up for care, it takes time to get enrolled. This is one, I think, of the easiest, lowest hanging fruits is most people who don't have healthcare coverage are actually eligible for coverage, and getting them in, working with community groups to get them coverage, I think, is one of the most important things we can do. It doesn't require passing a law. It doesn't require new regulations. It does require some work to try to help people who don't have much time, may not have a lot of sophistication, navigate the complex system that is health insurance in this country. But even if we got everyone healthcare insurance, that would do something, but not as much as you might think, to improving people's longevity and health. There is much more, as we all know, to health than getting healthcare services. One of our problems as a species as human beings, and this is true for all of us, is that we tend to prioritize the urgent over the important. You know this because we're constantly doing something that is causing us pain or something, rather than worry about things that are important that might be more long term. I know this as an academic, I'm always willing to do something that takes only a focus. In a day, I can get it done, rather than work for a year or two on getting a big project done. This emphasis on urgency as opposed to importance is one of the reasons we tend to focus on healthcare services, because they attend to us when we're feeling bad. That's when we access the healthcare system. But it turns out that if we really want to change, not just for others, but for ourselves, our health, it's much more important to affect what we call the social determinants of health, not healthcare coverage, but things like income, education, transportation, housing. Turns out those things have a much bigger impact on things like longevity, infant mortality, diabetes. Now, how do we impact those things? Well, the most important way we can impact those things turns out to be impacting and addressing the inequities in income and socioeconomic and educational outcomes. And that is extremely important. Sir Michael Marmot, who's a British researcher, looked at why in Britain, where you have universal coverage, very low pay to get in to see a doctor, there's no real difference in access to healthcare services. There turns out to be an enormous difference in things like life expectancy, heart disease, based upon income. And if we equalize that income, or certainly give people at the bottom a boost, that makes an enormous difference. Let me just give you some statistics. $1 increase in the minimum wage during the year before a child's birth increased their birth weight significantly and decreased the prematurity rate among those children. So give their parents, their mother in particular, an increase in minimum wage, and you can see a big change in children. Minimum wage increases also decrease suicide rates among people. It removes stressors in life to have more money. Not shocking to us, but we don't impact and use that in a public policy way. And we can see the sort of viciousness of some parts of our society when we've got governors who want to take away unemployment benefits because they think people aren't working hard enough or don't want to take jobs because they can make more money on unemployment. That is a total canard. If we made the wages more, that's what economics tells us. If we made the working conditions better, people would want to work. Penalizing them by removing unemployment assistance is hardly a way to improve health. It will only make things worse from a health standpoint. And we also know that giving people access to food, SNAP, food stamps, and WIC benefits for women, infants, and children, food, makes an enormous difference in terms of allowing children to grow up and decrease their risk of developing what's called metabolic syndrome, which is a pre-diabetic condition, and avoid diabetes. We know that if we can either decrease the differences and the disparities in socioeconomic income and other measures, or more importantly, just raise the bottom up, that can make a big difference. One of the things I have to say that impresses me about President Biden's agenda, and I had nothing to do with developing this, is the focus on families, universal pre-K, more child tax credits, more income tax credits, raising the minimum wage. All of these things actually might have a bigger impact on people's health and longevity and infant mortality than making reforms in the healthcare system. And it's important for us to kind of create structures. A better safety net will do a lot to improve the health of the population, especially people at the bottom. So with that, I want to conclude by saying that I think it's incumbent upon all of us to try to help raise the bottom and do what we can to raise people at the bottom and make their lives more secure so that they can lead a healthier life. Thank you, and I look forward to your questions.
With health outcomes in the US fairly similar to other developed countries, why is health care more expensive versus those other countries? And how can we bring down healthcare costs?
The simple answer is prices. When you compare the United States to other countries, we pay more per unit of healthcare than they do in other countries. Our MRIs, for example, $5,000, $6,000, where that in many other countries, they're below $500. We pay our surgeons more than they do in other countries. If you go to other countries, their hospitals are not as plush, frankly, as our hospitals. In the healthcare world, we often talk about the fact that, you know, it's hard to tell the difference between a hospital and the Four Seasons Hotel. So one of the major problems are prices. We've just have very high prices. One of the things I personally work on is to try to rethink the prices we pay for various services. You all know this from drugs and the drug costs, but it extends to almost every aspect. There's a second part, and that is, frankly, hospital concentration and hospital prices. Over the last 20 years or so, we've had this war between insurance companies and hospitals, each trying to increase the leverage they have over the other to try to drive their negotiations. And frankly, hospitals have won that race. They have, in many communities, a near monopoly, and that allows them to jack up prices that they charge to insurance companies substantially. And lots of studies have shown that those prices have increased. In addition, they've done a lot of mergers to increase their leverage. No evidence those mergers lead to more efficiencies, and plenty of evidence those mergers lead to higher prices. So that's a major, major cause. If we got our prices down, just of drugs are responsible for about a third of the difference in prices between the United States and Switzerland and Norway, the next highest countries on a per capita basis. So you're just paying a lot because you're paying a lot. And it's not so much that we use more services. In many cases, we don't use more services. We do have a lot of unnecessary care. We have a lot of administrative costs, but it really is about prices.
Thank you for that response. The next question that I'll ask is, what role, if any, do you think all payer rate setting should have in ongoing healthcare reform plans? And how might this impact the cost and delivery of care? Have you gotten this question before?
No, I'm just wondering, am I at Temple Sholem or I'm at my class at Wharton with my MBA students? That's where I get these kind of questions. So all payer rate setting is something that has been done in Maryland, which is that one of the problems of the American healthcare system, and this is pretty unique to the American healthcare system actually, is that each group that pays a different price. So Medicaid has a price, Medicare has a different price, even though they're both government programs. Private insurance has a different price. And by the way, each private insurer pays a different price for the exact same service, whether a hip replacement or a laboratory test. And so we have multiple prices. One of the things that was done in Maryland in the 1970s, because Maryland had very high hospital rates, was to say everyone's going to pay the same thing for hospitals. We're not having this variability. Medicaid is paying the same thing as Medicare, as private insurance. Medicare had to go up a little, Medicaid had to go up, but private insurance came down. It's the only state that has that uniform rate. I think it works. The evidence is that it has kept Maryland prices down over time. It certainly changes people's access to hospitals. Hospitals no longer play games to say minimize the number of Medicaid patients they have and maximize the number of private insurance patients they try to get. So I think it can make a difference. It's one step. And by the way, no state other than Maryland has ever been able to get that for a variety of reasons. It's one potential approach. But I think also changing what we pay. We tend to overpay for new technology. We need to pay that, and procedures, surgical procedures. We need to pay more for things that increase the value of healthcare, bring us more health rather than more technology. And they're not the same.
Right. What would those be?
Oh, things like going to the primary care doctor. Mental health, it turns out, is enormously important in terms of improving people's health, as well as actually bringing down costs if you provide it well and effectively to people with chronic illnesses. There are many other things, immunizations that we know improve health, well more than many procedures.
Yes, thank you. Here's a personal and professional question here, and that is, what aspects of the ACA do you feel were miscalculated, and how would you recommend tweaking or changing these policies going forward?
How long do we have? One of the problems of being involved intimately in the sausage making is the huge frustration and, the intention and what we ended up with. So let me just highlight a few things. First, let's be honest. The exchanges have underperformed. We have about 11 million people in the exchanges. Projections were we should be at 30, 40 million people. They just have not been that effective. I think we need to rethink them. Second, one of my biggest frustrations, and I think I personally didn't emphasize it enough, and I think no one in the end emphasized it enough, was we made the system more complex. We have by far the most complicated healthcare system in the world. My last book, I think you might have mentioned it, it's entitled, "Which Country Has the World's Best Healthcare?" And I went around to the United States and 10 other countries, Netherlands and Germany and Norway and Taiwan and Australia, to look. Our healthcare system is way more, order of magnitude more complicated than other systems. And one of the things we tend to do in America is layer on new programs rather than simplify. And one of the things we could have done is simplify, for example, Medicaid with the exchanges, with Medicare Advantage, and put them all into one exchange. That would have done a lot, actually, in terms of making it more competitive and I think simplifying the system. Second big problem is we didn't change how we paid doctors and hospitals enough and put enough teeth into that and accelerate it. I tried to do that. I was frustrated mostly by CMS, which runs Medicare and Medicaid, because they were worried they didn't have the computer systems and others to do so much payment change. Some of the payment change we've done has been good. Bundled payments and others, and we can go into those details if you want. But I think we need to experiment more. And the last thing is we developed something called the Patient-Centered Outcomes Research Institute to try to do experiments to find out, compare drugs head to head, or compare procedures with drugs, or compare different approaches. And I would say that over the last 10 years, it's hard to think that organization, which has gotten hundreds of millions of dollars, has done much good and really changed how we've practiced at all. It's been a sore disappointment of mine. I was one of the chief proponents of that and heavily involved in the legislation to actually put it in place. I think it's well underperformed. I'd also say that the parts of the bill we had to sort of remedy workforce problems, number of nurses and doctors and the debt that they have, and improve, for example, the number of mental health, just we didn't approach it right. I was not an advocate for the approach we did, and I think it's shown that we really haven't made a good dent because we didn't structure the program right. Thinking, all right, what are the two big hurdles we can take away and encourage people to do?
Well, I love this because I think that I don't love that answer, but I like the critique because I think it is instructional. And this next question, I think, will even help to fine tune where we might go, which is what role can government have in harnessing the resources and talents of our private provider system to be more populations outcome oriented and to improve access? And now here's the next piece. What are the first or most important 3 things you would recommend?
So the most important thing to do that, and I think the question is very sophisticated. All right, if we care about the outcomes, health, and not just getting services, what do we have to do? And I think the most important thing is we have to pay differently, right? I mean, right now, we pay for doctors to deliver services. If I say, you have that pain in your knee, I could operate and get a lot of money for operating, or we can get you some physical therapy. Surgeons don't make money by recommending physical therapy. They recommend, surgery, and they make money. We're paying for people to do things rather than to keep you healthy. It's no surprise we do things. Some of them are absolutely necessary. Many of them are not necessary or inefficiently done because doing it inefficiently can maybe get more money. So we have to pay differently. A large part of my research over the last 5 years is to devise systems for paying doctors and hospitals differently to get them to focus much more on keeping patients healthy. If you don't pay, for example, doctors based on how many patients they see in a day, but on a capitated basis, you cover or you care for 2,000 patients, we're going to pay you this fixed amount over the year. And you then are, we're going to measure your quality and we're going to measure how much you spend on them. We can get doctors to actually focus more on health and keeping people healthy rather than on doing each widget to make more money. And that is something the system is just really beginning to get its arms around. In the last 4 or 5 years, it's been moving. And I hope that over the next 5 or 10, it'll accelerate that movement to this change in payment. So that would be my top goal. And that's why getting the prices right also matters. So we're not just emphasizing doing lucrative things, but we're emphasizing doing things that we know are high value in terms of health.
I want to ask a follow-up with that and that's how do we harness the energy of this community? You see how sophisticated it is. You see these kinds of questions that people are asking. And so it makes me wonder, what would you recommend if you were part of Temple Sholem? And by the way, you're welcome to be an honorary member of Temple Sholem. What would you recommend to us? How do we harness that energy that you hear from these questions in order to make this a better system and make some of those changes?
Well, I think, again, I would emphasize 2 parts. One part is, I think, working not in the Temple Sholem community, because you're a well-off community, but working with community partners that service people who aren't so well off to try to get them coverage when they're eligible and to get them early services. So if you ask, what are the most important services you can deliver? They're really around birth in the early years. If we get that right for kids, that actually, lots of good data right out of the University of Chicago show that has a very long impact in terms of better education outcomes, better income for kids, less interaction with the criminal justice system. And so I think really focusing, thinking about a major initiative that really focuses in on better care prenatally, but also very importantly, we kind of forget once the baby's born, postnatally. You know, a lot of upper middle class women who deliver have doulas, and you know, it's like I understand it. You know, delivering and having a baby is super stressful, but the upper middle class people have very good social networks, and it's the poorer people who need the kind of support structures that doulas can provide. And it seems to me that is a big, big investment that goes a long way to helping mother and helping child. And I think figuring out that program for vulnerable parts of the Chicago community, you know, if you ask me what's the one thing you could do, that's probably one of the most important things that could be done. Figure out how to get people doulas. It turns out doulas aren't wildly expensive, and they can be very, very helpful, especially, and again, I emphasize, we tend to forget about the post-birth first 3, 4, 5, 6 months of a baby's life. Vitally, vitally important. And so I think partnering with communities to get access to those services, make sure when they're eligible, they can get health insurance and therefore better prenatal care, and then figure out how to partner with women who are pregnant, who are deprived economically and in other ways, and help them through that most stressful of all times. And enrichment. I will tell you, you know, one of my, when I have a colleague or someone that works in my departments has a baby, what I do is I send a collection of books and I tell them, start reading before the baby's born and just make it a habit right from the start. It's amazing the difference just that kind of small stuff makes because babies hear the words, and we know how important that is. They have the sort of calm time where they can, you know, there's a kind of harmony there that goes along with just reading a story and the modulation in the voice. All of those small things make a very, very big difference.
That is such a great recommendation. And I saw that Susan Can is on this presentation this evening. And I have a sense that women of Temple Sholem have just gotten a very beautiful idea for maybe another step to take. And I'll also say that Temple Sholem might be a little bit more economically diverse than maybe either than it once was or that you might realize. So
okay.
Absolutely. But I also love this opportunity to think about how we partner with other communities as well. The next question that I'll ask is, COVID-19 and the public health emergency has made clear that we need to increase access to mental and behavioral health care. So recently, telephone apps are offering real-time remote access to therapists. What policies can increase access to mental health? This person had written in distressed communities, but I have to say, I think most communities right now are fairly distressed.
So actually, what I spent my day doing was recording 4 lectures for my online course on healthcare reform in America. And one of the 4 lectures is about behavioral health and the challenges of behavioral health and how we can do it better. Let me say, first of all, it's an enormous problem. And by the way, it's an enormous problem in every country. There's no country that has solved this problem. We actually in the United States probably have more innovation around providing mental health. That doesn't mean we've solved it. We and the Dutch probably are the other country that really are trying new things to do this. So let me tell you, there are 2, I think, effective things we can do around providing better mental health. And we need to differentiate mental health, which is sort of more situational and for more mild cases. And again, no mental health when you've got the problem, it feels mild, but you know, anxiety disorders, situational depression, maybe post-bereavement depression and things like that, versus mental health issues for patients with serious and severe mental health issues like schizophrenia and bipolar disorder. Those are really require two different approaches. The sort of more mild approach, we know and that's really what's come out a lot in COVID. It's thrown people over in terms of anxiety and depression and related problems. What we know is that first, better services happen by what's called the collaborative care model. And the collaborative care model is a really simple idea, which is over 2 centuries, since psychiatry became a sort of specialty of its own in the early part of the 19th century, we've really kept mental health and traditional health separate, right? Everyone had a mental health hospital, which was separate from the traditional hospital. I trained at Mass Mental, which was separate from the Brigham, the Beth Israel, the Mass General, those big hospitals in Boston. And it's where we sent the mental patients. We also had psychiatrists who had separate notes from the regular doctors. They didn't write in the chart in the same way. We have to bring them together. And one of the things the collaborative care model does is say, look, we can't have the psychiatrist or the mental health specialist, whether psychiatric social workers or nurse practitioners or health psychologists, separate from the regular doctors. We need to bring them and co-locate them in the same facility so we can have what's called warm handoffs. The regular doctor can say, I'd like you to see my colleague, nurse practitioner, social worker, whomever. Those systems were developed initially over the last 30 years, really, in academic centers, but they work in the community. One of the big providers in the Chicago area, Aurora Advocate, or Advocate Aurora, whatever it's called, does do some of this co-location collaborative care model for primary care. So that's one thing that really the system is moving more closer to. We need more of it. Another is, as you mentioned, telemental health. Turns out lots of data showing it's just as effective as in person on average, whether it's for severe illness like PTSD or for depression and anxiety disorders. We have a lot of companies that have started up trying to make it easier to access services like that, and it works just as well. Our big problem is a problem of manpower or workforce, right? Manpower is sexist. Workforce, I guess, is the correct terminology. We don't have that many mental health workers capable of helping in the United States. You add everyone up, the psychiatrists, which there's remarkably few of, the psychiatric social workers, the nurse practitioners, the physician assistants, the health psychologists, you put them all together, we might have 400,000 in this country. That's one mental health provider for every 10,000 Americans. That is way, way inadequate. Just do the math on the back of your envelope. We have nowhere near enough mental health providers for the number of people who have mental health, could use mental health conditions. And so one of the things we do need to do is increase the supply of the workforce and be able to deploy them more effectively. That also means things like making sure we don't have so many missed appointments and even small tweaks can make a very, very big difference. Telemedicine does enhance actually the use of that workforce. So their co-location, more use of telemental health, and then a long-term play to increase the number of mental health providers in this country.
Well, and I'll say as a rabbi who is right now.
We don't count you as a mental health provider, but you really are.
Well, what I'll say also is that I make referrals around when people have more acute issues. And right now, being able to find people, the therapists that they deserve, has been very difficult. It's a huge challenge.
Yeah.
So this next question is for the layperson. So specifically, please speak right to me. How would you define bioethics or medical ethics? And what are the academic boundaries of bioethics as a discipline separate from other branches of medicine as such is practiced?
Well, bioethics is simply the examination of the ethical dilemmas that come up in biology and biomedicine and the delivery of healthcare. Medical ethics tends to be focused on things in the healthcare setting and giving care. Bioethics can be broader. It can include environmental ethics. It can even include space ethics. We can talk a little bit about that when you send up animals into space or even land them on another planet. So that's what it does. And there's a wide range, you know, from the physician-patient encounter and truth-telling and not having sex with your patients to things like reproductive ethics, to issues related to the allocation of resources, end-of-life care, euthanasia and assisted suicide. I mean, so there's a very wide range. I would say personally, I haven't covered all of it because I don't really do reproductive ethics. I do almost all the other parts of it. But over the last few years, and certainly during COVID, my main focus has been on allocation of the scarce resources related to COVID, whether they're vaccines or respirators or things like that.
So we have a question about Kaiser in California has addressed the fee for procedure problem. Are you familiar with that approach? And if so, what do you think of it?
Well, I'm not sure what you mean by have addressed. Kaiser has a different system in the way it pays its doctors and the other healthcare workers. It doesn't typically pay them fee for service, but it does pay them on a more salary basis. You know, salary has some advantages and it has some disadvantages. So it's got some better ways of working. The person, and I'm going to project, I mean, one of the biggest changes coming out of California in terms of payment is what's called the reference pricing. And that is where, and that's done by what's called CalPERS, the California Public Employee Retirement System. So the pension system in California for teachers and police and others. And what they do is say, look, you want a cataract surgery, you want hip replacement, we're going to pay X dollars, 28,000, whatever the number is, for the whole kit and caboodle, the doctor, the hospital, the implant. Here are a bunch of places that do it, and we think their quality is good. You want to go to somewhere else, you want to say maybe go to UCSF or UCLA and their price is higher, you pay the difference. And it's remarkable for two things. First, people really do go to the lower cost places, although that effect is not as great as you might think. But the other effect is places that have really high prices, they bring those prices down. That system, what's called reference pricing, I think there is, especially for procedures, there is a lot of virtue in that approach. We have to just make it more systematic.
Great, and that was that person's follow-up. So thank you for that. You anticipated their next line of questioning, so thank you. I want to go back. This is on the mental health care provider scarcity. And do you think we can get to a point of breaking down the state licensing barriers?
That is a great question, and I certainly hope so. And the reason I think we might have a chance now is COVID and telemedicine. So one of the things that telemedicine has done is to say, you know, I live in Washington, D.C., and I can provide care to you living in Illinois and working across states. If I'm certified to work in Washington, D.C., I should be able to provide care in Illinois. We've had a system, you know, federalism that has given the states power over a variety of things, including licensure of professionals. I think one of the things we're recognizing is, and that might not be such a hotsy-totsy system in an era of the internet, in an era of being able to provide care across state lines over the internet. And so I do think this is a place where the government, through its regulation, can actually have a lot of influence on states to have reciprocity, permit the telemedicine to stay. And it actually could do a lot to facilitate telemedicine linkages, especially from rural areas to more urban areas where, you're not going to have these well-staffed hospitals in rural areas, but you might have a telemedicine link so that the cardiologist is in Chicago providing help in South Dakota, or the gastroenterologist is being able to provide care to patients in other rural areas.
This is a question about residency programs. Do you foresee Congress lifting the limit of residency programs to increase the number of healthcare providers, since that is federally controlled?
I doubt it, and I doubt it because there's, Congress is constantly looking at the money it pays for the residency programs and wondering, why are we paying for these residency programs? It's not a super huge amount of money, but academic healthcare centers really care about it, and I don't think Congress is going to change it, because Congress's intuition is to keep the price down, even if healthcare centers want more. And I'm not sure I'm not sure what we need is more doctors in the system. We need some kinds of doctors. We need more primary care doctors. We need more pediatric specialists. We need more psychiatrists. But it's not clear to me we need more urologists or orthopedists. And so what we need to do is to change the balance. And the best way to change the balance is, I think, two things. One is to increase the pay for those docs that we need more of. You don't have to be an economic genius. You just have to believe a little bit in Adam Smith and modern economics to say, well, you want more of X, pay more for X. The other thing it does seem to me is change how we pay for medical training. I have long been an advocate of what I call forgivable loans. Let's pay for medical school for every student in America. Not that actually, when you think about the $4 trillion or nearly $4 trillion we're spending on healthcare, the medical training for all the medical students in America, I don't know how many there are now, that 70,000, 80,000 per year, not that much money. And say, all right, you have to pay back that loan if you take it. But if you do primary care, work in the inner city, work in rural areas, do a pediatric specialty, psychiatry, we're going to forgive that loan. They do it for the military, and it seems to me it's a very important thing we could do for those specialties where we need more people without increasing the total number of doctors.
The Cantor and I made eye contact for a moment there, hoping that you were also going to include clergy in the debt forgiveness around student loans. But okay, well that'll be second tier. So now asking some of these questions about ultimate health and what we do to get there in different communities, and really addressing some of the social issues. So I think I'll ask one, and then I'll follow it up with another. Can you speak to the problem of hospital closures in disadvantaged communities, including in Chicago, and how can we reverse this trend, and what is being done to preserve healthcare facilities in vulnerable communities?
Well, it's a double-edged sword. Many places, Chicago included, have too many hospital beds. The problem is that hospitals tend to make a lot of money on privately insured patients, and in distressed communities, they don't have a lot of privately insured patients, and so they have lower reimbursement. This goes back to the question, I think the second question asked about all payer rate setting, where everyone's paying the same rate. That is one way of addressing this problem. But there's also a problem of efficiently run hospitals. One of the things I think that hospitals are not the most efficient places in America. And they really do need to have a big step up in the efficiency with which they operate. And this is a very, very important problem. Most hospitals have no idea what it costs to do anything. They tell you what the average cost is, and they're paying me under the average, but that isn't the cost, right? That isn't looking at time motion studies of what it takes to actually deliver care. And so they're not very good at how to make those services more efficient. And I think that's something we need to encourage and get our arms around. But we need to change the payment system. Again, I emphasize this because too much of the revenue for hospitals is from private insurance for procedures and not enough for the other things that they do that's really important. But let me also emphasize, one of the things COVID has made clear, and I've been talking about this for a decade now, since passage of the Affordable Care Act, is we're going to have a shift of care out of the hospital. And we should have a shift of care out of the hospital. We can do much, much, much more, things we never thought possible outside of a hospital. A hip replacement as a surgery center, chemotherapy in patients' homes. The list goes on. We shouldn't try to preserve or keep hospitals just to keep hospitals. We should remember what's the goal we're trying to do with the healthcare service and do it in the right place. And I'd say more than for many, many services, that right place is the house and not in a hospital bed. And I think the closing of hospitals is not, I think, the tragedy many people think it is. We do need to make sure that they're properly distributed, and we don't only have hospitals on the North Shore or in rich areas, but that shouldn't be confused with, maybe it is right that some hospitals close.
Thank you. Thank you for that response. So I think that this might be the last question or the penultimate question. We'll see. As you mentioned, medical care is a small portion of health. So many SDOHs have been crafted to discriminate. Here in Chicago, we've had redlining, highway planning, school and hospital placement. Evanston recently voted to approve a program that gives home purchase dollars to underserved populations. So how can we convince our governments to invest the money to overcome centuries of systemic racism?
Well, I think that there are probably 2 or 3 things to really do. And the first one I would say is we've got to raise the minimum wage and not be shy about it. Let me just say, I find it quite amazing that we're fighting over $15 an hour. And I want everyone in the audience here to think through $15 an hour times 2,000 hours a year, which is what average work is if you do 40 hours a week over 50 weeks. So we're not talking about a lot of vacation. That's $30,000. That's not a living wage. Only if you have 2 people working in a family. That's not the way it was in the 50s. Now, remember, $15 an hour is what we're fighting about. But if we actually look at the history of the minimum wage in America and calibrate it for inflation, actually, in 1968, we were paying the equivalent of $22 an hour as the minimum wage. Now that, over 2,000 hours, is $44,000, $45,000. Now we're talking real money. So I think one thing we can do is raise the minimum wage. Let's not faff about and argue about $15 an hour. That's where we should be today. The second thing we can do is shore up the safety net. We have a lot of programs. One of the problems is we have a lot of programs and it's confusing and it's hard and it takes a lot of time navigating them. We should consolidate those safety net programs. I think whether it's earned income tax credit, child tax credit, SNAP for food stamps, WIC, and the housing, various housing programs, we should consolidate them into cash transfers and allow people to spend the money. They do it in general responsibly. Lots of studies have shown that, and it helps people. And the last thing I would say is I'd go back to the thing I said about doulas and early childhood interventions. If we really, really want to enhance over the long term and make a structural change, we got to give children the best possible start, especially children born into poverty. That's the critical moment, the first few years of life. And I think heavily investing, whether it's doulas or nurse family partnerships or those kind of things, those are the three programs I would heavily emphasize, and I think are very, very important.
Zeke, thank you so much. I so appreciate, we so appreciate that you are intelligent and provocative and kind and experienced, and you bring that all to our virtual Bima. And you truly are the kind of person who has this nice, beautiful legacy of being one of our distinguished speakers that changes us so that we can change the world. And I want to say thank you. And we'll begin with ourselves, and then we'll go to our family, and then we'll go to our larger community and to our nation and to our world. But really at the way in which you are urging us to, you've given us these concrete steps. And so we thank you, and your perspective has given us so much both to think about and to act upon. So thank you.
Thank you. It's a tremendous honor to be able to come to, even if virtually, to Temple Sholem and participate. It played a big role in my childhood, and I'm very honored that you think I was distinguished enough to be on your Bima.
Thank you. And I'll say that I hear Jan and Bruce Trannon, even though we can't really hear all the participants here, I still hear them. And they're saying, come back when you can come in person, be on our Bima. Bruce and
my
Jan,
mother would love that.
Well, and we really want to make your mom happy. And you did say much about how those first years are so important, and she certainly did right by you and by our whole world by the way she nurtured you in your first years. So yeah, why don't we make her happy and bring you to Temple Sholem again, and in that way make our whole community better. So thank you so much. And I'll say that Bruce and Jan Trannon are responsible for bringing you, as they have, through their generosity, been able to say that annually Temple Sholem can and must have a distinguished speaker who will speak on the issues of our day with moral clarity so that we have moral courage to act on those issues. So we want to thank Bruce and Jan Trannon for their incredible vision. And we want to take this moment now, this evening, to say that this has been the close of our inaugural Distinguished Speaker Series program. And as such, then we want to be able to close this by being able to mark this occasion, thanking God for giving us life, for sustaining us and allowing us to reach this time, so that in that way, we pave the way for the next moment of how we will take action on these issues, inspired by distinguished speakers like ours this evening. Again, Dr. Ezekiel, Emanuel, Zeke, thank you. And please join us in the Shehechianu.
Baruch atah Adonai Eloheinu melech haolam shehechianu v'kiyamanu v'higianu l'hazman hazeh.
Thank you, Cantor. Thank you, Zeke. Thank you, Bruce and Jan, and thank you to our extraordinary community. Thank you to Allison Barker, who helped to organize this as our development associate. Thank you to our clergy. Thank you to our extraordinary staff. Thank you, Stacy, for making sure that all the kinks got worked out in this evening. Thank you, Allison. And most of all, Zeke, thank you for your wisdom and thank you for your charge. Laila Tova, everyone.